BMW?
BMW is a good way. Okay,
Yes.
wait.
Okay.
University. ولا elite. 5000 هبل.
Where's the wire?
BM University ولا elite.
ندي 5
تمام.
عدي ايفك.
اوكي شريف هنجيب لنا ريتن.
اساسي.
اتس اوكي.
Yeah, it's okay.
سكرين يعني
يسري.
BMW.
ايوه. الاثنين معي.
اوكي ممكن.
Curiosity.
Yes. I hear you, Dr. Ahmed. Do you hear me, Dr. Ahmed?
طيب ما انا عاوز اسمعه بقى.
دكتور احمد فتحي.
وبعدين النقطة هنا كده. Curiosity.
ايوه دكتور احمد سامعني حضرتك؟
Yes.
Yes.
I can hear you.
Okay. Now we will start. I'll present the clinical data of these patients.
Wait for curiosity. Okay. Please ask the people outside if to answer. Curiosity, will you present the clinical data of the patient?
Ready, Dr. Ahmed?
Yes, ready. Curiosity.
Okay. A male patient, 56 years old. He is.
معانا الدكتور حسام قنديل والدكتور عادل امام.
برحب بكل الاساتذه اللي شرفونا من القصر العيني وكل اساتذه معهد القلب.
الدكتور محمد غني والدكتور رضا القاعدين بيتفرجوا معانا يعني هيشاركوا معانا.
Male patient, 56-year-old. He is not hypertensive, but he is diabetic, and he is a heavy smoker, presented by typical anginal chest pain, exertional, Canadian class 2 chest pain. ECG showed the T-wave inversion in the inferior leads, and echocardiography showed fair or normal left ventricular functions about 50%, but has a regional wall motion abnormality affecting the inferior wall with type 2 diastolic dysfunction. The coronary angio showed right coronary lesion. It's a tight lesion, mid segment, and it's nearly a focal stenosis.
Just why?
But the left system showed the distal left main encroaching on the osteo of the LED.
بيتحط على المونيتور بتاع الانجو عشان لو في الانجو هنستفيد.
اوكي يا دكتور هم مش شايفين المونيتور.
فاكر اللي عند الرايت كوروني كاست.
عايزين نصور هنا.
احنا عارفين احنا عاوزين في الانجو.
اوكي.
احنا عايزين نحدد.
ظبطت يا دكتور احمد. Is it okay?
اوكي.
Okay.
So make angel.
Okay.
The first one.
فانت بتقول ان هو عيان عنده 59 سنه
56 سنه يا دكتور حسام.
وايه بقى مشكلته؟
مشكلته هو diabetic ex smoker presented بكلاس 2 Canada class 2 chest pain في inferior wall ECG changes in the form of T-wave inversion with echo normal ejection fraction 50% with regional wall motion affecting the inferior wall.
والدايجنوستيك انجو طلع فيه
كان distal left main significant distal left main encroaching the ostium of the LED with nearly some involvement of the ramus branch with tight lesion in the mid segment of the right coronary artery.
ميد سيجمنت رايت كورونري؟
Yes.
وده اللي انت هتعمله دلوقتي رايت كورونري؟
Professor Robert preferred to fix a stent in the right coronary to support the circulation before tackling the left main.
Okay. Yes, we discussed this in the morning with Professor Robert.
So let's make angel. Just to have a tracing.
And the right coronary is super dominant with tight distal lesion in the mid right coronary. We prefer to start with the fixation of the right coronary first, and then go to this is the right coronary. The debate whether it seems to be an easy lesion, if you know it's not an easy, it may be synthetic and sometimes some difficulty, we need rosa, we need cutting balloon, we need cold balloon.
It's a huge right coronary. It's a huge right coronary.
So the dominance of right coronary artery was the reason that I asked for right coronary intervention as the first stage of the revascularization. You cannot image any troubles with left main with not so good support from right side.
But you expect this to be difficult in intervention for the right coronary?
You never know. It's calcified. We have to predilate. I believe we will succeed without big dissection, these kind of things. Anyway, we need good TIMI free flow before we start left main treatment.
Yeah.
It's okay.
We see report that you are working with left radial, which guiding you affect the right coronary.
You know, 90% of cases in my institution are performed with with left radial access. I strongly recommend it because, first of all, you can use classical, traditional guides for femoral access. This is very good for people starting radial program. It should be taken into consideration because, as you know very well, one of the milestones for good coronary percutaneous intervention is just to have a good support. The second thing is that ambulation of the patient is very easy. This is also important in time of restrictions, financial restrictions in health care in every country. So therefore, taking also into account the data from many trials that even for acute coronary syndrome patients, radial access is better, doesn't prolong the time of intervention, radiation and amount of contrast medium. So we decided totally change access in 2005. So we started from 25–30% of cases. Right now it's around 90 with radial. Okay, so and then I propose not to exceed 2.5 12 millimeters balloon, just to predilate. Whether it's not only calcium, might be some fibrosis, and then we can stent it.
In most of our Egyptian patients, the degree of calcification that we used to see in the European elderly patients is not the same.
We need a balloon,
2.5 soft black, that would yield to balloon without difficulty. I could see that the wire went on without difficulty as well.
We can start with NC. Yeah.
Is it okay for the wire?
It's okay. It's okay.
Which wire do you use?
We started with universal BMW. You know, the access was not very, let's say, difficult. Also, the course of artery is not so bad. So therefore, we have something with a good balance between support, steerability. Okay,
last one.
2.56. Okay, we can go. Okay.
What do you think about one more value of left radial regarding the radiation exposure to the operator?
You know, first of all, what I see here, we should change a little bit right now. The second, probably you are right. From this access, might be this exposure is a little bit bigger, but since we changed the position of the hand very close to right femoral, I'm not afraid that this difference will be significant. So we have 2.5 by 6 on the table right now. So we'll try to fix it. Now I see that because of the first angulation with this catheter we can have some troubles with stent, but since we don't expect to use long stent, probably we'll fix it without changing of the guides.
So this is a pre-dilatation now? Or is that
This is pre-dilatation.
2.5 balloon.
2.5. You know the artery is 4.
Yes.
So therefore we don't want to be very aggressive. Just
You didn't want to do direct stent.
exactly. But this is NC balloon because I suspect that lesion is not so soft, I would say. Then that was also a test whether the stent will go with this first bend.
Yeah, I'm expecting it to yield quite easily.
Yeah. Okay. Just confirm the position. So this is very convenient, very comfortable to work with very experienced team right here.
Thank you.
I really appreciate their experience. They are fast, precise.
Inflate.
Yes. But slowly, not so fast because this is a short balloon. You know, in case of short balloons, the inflation should be now it shifted a little bit, so you have to change. Yeah. This is always the same with short balloons.
The melon seed movement.
Yeah.
If you have the balloon moving away from the lesion, there is.
You inflate to 4, up to 4, then try confirm the position.
I think this is the value of longer balloon. If you
yeah, but you know sometimes you order
the balloon.
4, 6,
Slowly upgrading the person.
7, 8,
Yeah, it's,
9, 10.
it's difficult to see any indentation on this balloon.
Okay, 12.
Yeah. 2.5, 6 millimeters.
But you know, this is always very important message from such a situation. When you don't see indentation, when you see the effect with the angio, you can predict that there will be no problem with stent apposition.
Yes, yes.
ساعات بيحصل مع الشورت بالون لما يكون الليجن فيري تايت او كالسيفيك البالونه تبقى
Water melon.
ووتر ميلون longer balloon is good.
Let's make angio. We need to see the result. So let's have a look. What we have achieved. Okay, as you see, it's opened in a half. Yeah. As we expected, probably this is a calcific nodule, not circumferential ring of calcium. So it's also very important message for possible stents usage. Okay, so now we have two possibilities. I ask panelists what they prefer, to test with bigger balloon or just to go with a stent.
Go with the stent.
Okay, thank you. We accept. So
I think
we need
3.5 stent rather than 4.
You know, this is in my opinion, this is 4 millimeter vessel.
Yeah, but I think 3.5 on high pressure will be good enough, or maybe 4 will be a little bit.
Basically, it's 4.
I would say let's take 4 because this is 4. We will have some problems with passages, but we need 12 millimeters long. It's enough, I guess, and 4.0 as a size.
All right.
I think 4 is okay.
A regular drug-eluting balloon.
لا عملي.
ممكن يحصل شوية.
Ulti master.
Why not?
That's okay. 14. Very rapid.
So the choice is for Altamaster from Terumo. As I know, this is not bad stent. This is a let's say new generation of Terumo stent. I don't have let's say big experience with this stent because Japanese devices are very expensive in Europe. They have to pay a special tax delivering in our market. You know, this is a self-defense from European community.
Yes, yeah. But we know we have very good experience.
Yeah, this is really good stent.
It's a good stent.
I would stress the point that we decided for 6 French catheter, also for left main.
I think with a big inner opening here. It's big inner
Yeah.
diameter, yes.
مستنيين ايه يا دكتور يسري؟
Waiting for size of stent 4 by 12.
ده الصوت مش واضح بتاع الدكتور يسري.
مستنيين الستنت سايز اوف ستنت لينس اوف ستنت هو عايز ستنت 4 12.
4 by 12?
Yes.
مش لاقيينه؟
لا بنجيبه.
12 is not shown?
1 minute. Less than 1 minute.
You know what I was tough in Egypt in 2012 and in 2013? That let's say internal silence and ability to let's say to wait is a basic thing. So probably in my lab I would shout on my team, but now that's life.
Yeah.
معلش. أبين؟
طبيعي يعني؟
عادي.
So, Robert, you prefer the left radial approach because you select guiding and casters like the femoral, but with downsizing 0.5 inch, or you keep the same size?
You know. First of all, as I told, that the support from guide is a basic for final success. Then the second thing is aggressivity of the guides. You know, this is not my observation, but all of you with so big experience know very well that Judkins catheters are more elegant, more gentle compared to others. So, but they were designed for femoral access. And then with this left radial access, you can copy this access. So you have, with regular guides, the same support. This is very important in my opinion. Then if you have possibility to change the position of the patient's hands, you really have very convenient, comfortable situation for maneuvers on the, let's say, on the guide.
هم كل ده دكتور يسري بيجيبوا ضمانة؟
لا خلاص يا بيه، احنا المشكله كانت في اللانس 4 موجوده، بس هي كانت اللانس
خلاص جت اهي
4 12. احنا introducing the stent now.
And now the crucial point will be just entering of the right coronary artery. Usually I ask patients to take a deep breath, but even without that, this short stent went very well. But look, without very small support, that was possible. As you see, this team is very well experienced. I'm not necessary here.
No.
Okay,
I think it's okay.
I like it.
Okay.
This is business as usual for most interventional cardiologists.
2, 4, 6, 8, 10.
Okay. Up to nominal.
What is the pressure?
12.
The nominal is
Nominal 9.
is 9. Okay, it's okay. 10, 9. Okay.
Okay.
Let's say deflate right now. Wait a moment, and with the balloon in place,
Okay.
make angio. Whether we have TIMI free flow.
Guiding bar or right?
Okay,
What
great.
should be a guiding?
Then I would no, just I would repeat it.
You remove the balloon.
No, don't move the balloon in the same position.
Okay.
Then once more.
Clear?
Yes.
Okay.
And now we'll make 14.
Okay.
High pressure ballooning,
2,
because I still have in my mind this calcific nodule
8, 10, 14.
to 14
Okay.
exactly.
12, 14.
And 15 seconds. The shortest time for balloon inflation is 15 seconds. We have to give a time for vessel to accommodate to the balloon and stand.
What is the pressure now?
14.
14.
Okay,
That's
deflate.
why are you doing 2 stages? Because you are.
I will tell you. Then pull back the balloon, and then we will check into projections. First of all, the first time, the first inflation was only for nominal, not to exceed, and let's say to be very safe for the vessel. I was afraid of this calcific nodule. Since I looked that there is no elastic recoil, take care of the tip of the wire.
Yes.
Don't lose it. Okay. And then, since everything was fine, we repeat it with the higher pressure. Okay. Then we need 2 shots. Okay, and contralateral. No. Right, just right.
REO.
Just right. Okay. And then I will ask you to accept for exception.
Yes,
Yeah, accept it.
the result accepted for us.
Okay. I hope you like it.
Yes,
It's
it's
okay.
If yes, we'll skip, let's say, the right coronary artery, and then we have to exchange the guide. Yeah. Please take it out.
this is what our regular first or second year fellow case that will do every day.
There is no doubt that in such an institution, and here, National Heart Institute, with let's say 7,000 of procedures, I guess not only percutaneous but mainly that the quality of staff is really very high, and their education on a very good level.
Thank you.
The second artery, the left coronary system, is much more demanding. This is the true, but I would say that at least half of the Judkins left.
Left 3.5.
I would like to bring your attention to the fact that with this left radial, we were able to perform with regular right Judkins procedure. The same I would love to have with left coronary system. Just 3.5 left Judkins, 6 French. And just to continue, so this is not only my opinion, but at least my mentor, Professor Serrois, that almost half of the, it means 50% of the chances to succeed with the percutaneous coronary intervention is a philosophy. is understanding the anatomy, physiology, trying to adopt techniques for the patient's needs. And I hope you will understand the approach when you see the left coronary system.
Are you going to use the dedicated bifurcation stent?
Okay, 4. So we have Judkins left 4, 3.5 is not available.
Are you going to use the bifurcation stent?
Okay, so available, 3.5. Excuse me, could you repeat it?
Will you use a dedicated stent for the left main?
Robert,
Yes.
are you going to use the bifurcation stent, the Bolton?
Yes, I believe that it will be interesting option for you. Looking at the diagnostic angiography, I saw the indications for that. I will try to explain why when you see the angiography, okay?
Okay.
Because the report, I saw the diagnostic angio in the morning, but the people is not seeing. I just want to one injection to see the diagnostic, because as I remember, there is a long left main and distal, including the ocular LAD disease, and circumflex is a small artery, right? And you select the guiding left 3.5, Judkins left 3.5, right?
No. We selected Judkins left 3.5.
And here there is a long left main, and you are concerned with the active and passive support. For me, I would like to go with some like ABU, XP, ECARI, the one with ABU2.
I will tell you like that. Have you ever heard about long distortion, let's say, longitudinal stent distortion? Probably yes. And the more aggressive guide you use, the possibility of this damage is very likely, especially for left main. So therefore, I always try to use, let's say, not aggressive guides, especially when the lesion is so close to left main. This is distal and ostial LAD.
You want this projection? Or?
First, we need spider,
Yes.
face spider, just to show the people. Okay, but look at that. This is yeah. No. More. No, more condyle. Just
See that the Judkins left is not well oriented.
no. Just put 40, 20. Okay, now make it.
Set it out.
How is the pressure in the left main guiding?
Pressure is okay, it's 140/80.
Believe me, with this gentle, but we don't need these wires. Okay, yeah.
Okay.
Take a picture.
Okay, take a picture. Okay, once. Then 40-20, as I said.
40/20, NO, 40/20.
Because this is not typical spider. Now will be typical. Forty, 20. 40-20.
40 here,
Yes.
40. Code at 40, 20 LO.
Anyone need to comment on the selection of guiding for this short long left main?
السمع
Long left main with distal ostial.
Yes. Okay.
Left
Okay.
main and the ostial.
Now you will appreciate in this view the LAD, and then now we need much more caudal. So caudal 40, a little bit right. Yeah. Just okay. And center. Yeah. Now you see everything.
Yeah, now it's okay for us. Judkin 3.5 is okay, but I know that Judkin 3.5 is not giving an active support, just passive support, and it's well aligned.
But believe me, we don't need strong support.
If you don't need the active support in addition, it's okay. It will be okay.
This is the point. In my opinion, we don't need strong support.
Yeah.
Now we have a situation where this kind of trifurcation is visible. So in my institution, I always in such a situation insert 3 wires, not 2, but 3. So what is your opinion?
Yes, Dr. Adil, would you like to insert? We have optical LED, we have like Ramus branch is sizable, and we have also in addition circumflex non-dominant but sizable also.
Yeah.
Would you go with 2 or 3 wires?
Okay.
Or 1
first
wire?
LED. First LED. Why a first LED? Okay.
2 wires.
2 wires. One in the Ramus and one in the LED.
Yes.
Yeah, because the light shift possibility to the circumflex is
Circle far away.
low.
I think I will do FFR to the ramus and the circumflex, and if they are not diseased or they don't have any problem, I will send from the left into the LED directly, no problem.
Without wiring of the...
Without wiring of anything else.
There is debate. One wire is satisfactory if we have data with FFR that of the ramus and circumflex is not so much included, and Dr. Adil only 2 wires, one in the circ and one in the ramus and one in the LED. And for you take 3 wires because
So I would
is there any possibility the circumflex will be included in the black test?
sorry that I interrupt you, but this is very important. My colleague right now changed the projection for cranial to see whether LED wire is positioned properly. So this is a very educative and important. Now we need a second wire for circumflex artery. The question was, and once more I would like to repeat it, what do you think about the wiring of this ramus? Because you know we can call it trifurcation, false trifurcation. Anyway, this branch is equal to circumflex, and of course we shouldn't lost it.
Do you think that this ramus with this size can be difficultly rewired if any black shift happens?
Yeah.
I have no problem with wiring the 3 branches. No, I have no problem with that at all. But I think the disease burden is mainly at the LED. At least from the views that we have seen, I don't see any major disease burden in the circumflex or the ramus.
Our primary plan was to perform IVUS for LED and left main after wiring, because I agree with you that the plaque is mainly located in the orifice of LED.
Yeah.
So I agree with you that we can secure these 2 branches. I mean circumflex and ramus. But you have to remember that without debulking of the atherosclerotic plaque, after balloon dilatation and then after stent implantation, plaque shift plus carina shift can close the ramus.
So I think it is, if you're going to have IVUS, it's necessary to protect the wire.
This is the true. So therefore we will use also the 3rd wire. So the colleague right now tries to wire the circumflex artery. He didn't change the tip of the BMW. Hopefully will succeed. It seems to be ramus probably. No. Okay. This is circumflex.
دي واحد تست يا مس. ايوه حلو.
Just a couple of words on longitudinal stent distortion. The problem is that if you aggressively touch the edge of the stent with the guide, aggressive guide, as for example extra backup or it's okay. Then we need a third wire. Then you can destroy the stent. The stent is shortened with let's say with the thickness on the course of stent, which of course impairs the radial forces and needs additional stent implantation.
How frequent do you use the Judkin left guiding in your daily intervention?
I would say that 50% Judkins left, 50 extra backup.
Okay.
But I must honestly say that if I see not very difficult anatomy, not very distal positioned lesion, I start with Judkins left. If the anatomy is difficult, where there is so many tortuosity, calcifications, yes, I start with extra backup. Left amplats theoretically only for very difficult circumflex arteries.
Do you have in this case a certain strategy for
Yes.
this bifurcation lesion?
Yes, the only I would like to make this strategy based on IVUS investigation. If not, I usually use pre-dilatation as a so-called IVUS for poor people, trying to assess the behavior and of the balloon and response of the vessel.
Yes, this patient was found by IVUS, but the problem is the IVUS cannot be settled in this tool.
Yeah, I know, but it's not.
Yeah,
but let's make this
so
interesting.
consider that you are doing without IVUS.
Yeah, if you don't have IVUS, you do the poor man.
Yes, exactly.
Yeah. Would you expect that this patient will go well with provisional stenting or with?
Always in such a situation, I start with provisional T-stenting, let's say, approach. Why? Because I see, let's say, the real lesion. The real lesion I see only in the orifice of LAD. So therefore, I believe that one stent from left main towards circumflex, towards LAD, can solve the problem. The stent which I presented to you this morning has this possibility to get, let's say, to deliver a good access to circumflex and to ramus properly positioned. Okay, so let's see what we have achieved. Okay. Yes, we have 3 wires, and now since we don't have IVUS, we need to predilate this LAD lesion. I would use 12 millimeters NC.
بالونه 312 NC non compliant.
For the left main LAD or for other press?
Only for LAD orifice, but of course part of the balloon will be in the left main.
Will you do also
Longer.
ballooning to
You
the
have only 12? Do you have 12?
complex?
12 أو 15 and
No, 10. Okay, let's. Okay, again we have small problem. we don't have 12. I don't want to use longer, not to touch the lesion, so therefore we are forced to use 10. But the team is very precise, we will manage.
Are you using 6 French?
Yes, this is 6 French.
Yeah.
But I don't expect the necessity to make ballooning for, let's say, simultaneous ballooning for 3 vessels. Hopefully, we will avoid it.
And such lesion you are preparing, planning for stent strategy. Can you tell us how to define stent size, inflation pressure for this eccentric lesion?
Yeah, I will try to comment every
after balloon or before?
after balloon. After balloon, we have to enlarge the LAD after ballooning, because this should be 3.5 at least. A little bit forward. Yeah, that's good.
The 3015?
This is 3010.
10. NC.
NC. A little bit back and slowly. The inflate slowly.
Okay.
You have to position. Okay, good. Yeah.
2, 3.
No, it went into the LAD. The always problem with short stents, as we already mentioned. No. Just inflate, but slowly. Then I will try to make.
Okay. 2,
Okay.
3, 4,
Sure.
5,
Okay. Go.
6, 7, 8,
Go.
9,
And 10.
10.
And stop. Yeah. Show me. Register. It's a little, but it's it is good. Go to 14.
Okay. 20, 12,
Yeah.
30, 40.
Okay. Open. Yeah, and make engine. Okay. Now we will see the result. So first we have to say this is staph lesion.
We need to know how much pressure you inflated.
We let's say use only 14. We used 14 atmospheres. So we need bigger balloon. So we need 3.5
Okay.
and longer. 12.
If the balloon
Okay,
is
15.
in such lesion, this inflation without difficulty, without implication, is giving you some choice to go with the stent after that, or you need more preparation?
I would say like that now I see asymmetric lesion, because in a case of symmetric I would take scoring balloon or
Some from the chairpersons say that you can stent in this stage and then post-dilate.
First of all, since I decided to use this dedicated stent, there is a gap. This gap, when this gap fits into the let's say this nodule, we will have not very good results. So therefore, in such a situation, I try to increase aggressiveness of the pre-dilatation.
But what if you are going to use a regular DAS stent?
Because with regular stent, the possibility of losing at least ramus marginal is very big. You have to remember about the about the plaque accumulation, about the plaque shift, carina shift.
No, I mean for the audience, because this practice of using further ballooning from 3.0 into 3.5 in this lesion is done only because of this dedicated stent.
No, not at all. This is not the true, because without in any situation I would use 3.5 as well.
You start with 3.5 from the start, or start with 3 and then go 3.5?
No. Might be I didn't catch your point, but
3.510.
I know you started with 3 and then you're upgrading into 3.5.
exactly.
And the rationale for this is to prepare the lesion.
It is prepared to lesion. Doesn't matter what kind of stent will be used.
Okay.
But I was talking about the dedicated.
3.7.
But the chances of
3.7.
the new stent, the dedicated bifurcation stent, is that the branches will have better chance to
3.5
remain
then.
open after the
3.5.
Ah, okay. 3.5
This is not a semi-compliant.
That doesn't matter. Okay, doesn't
Okay.
matter. Okay. So we are forced to use semi-compliant 3.5 by 10. So this will be also the answer how much calcium we have within the lesion. The situation is similar to the lesion in right coronary artery that was also asymmetric with some calcium. It doesn't matter what kind of stent we would decide to use for this particular, let's say, lesion. The preparation that it was, let's say, presented during the great lecture, interventional let's say, percutaneous coronary interventions, reality and theory, that lesion preparation is mandatory. Okay, and again. Okay.
I think most of us in the room would go for the stent after doing the first balloon inflation with the 3-0.
2, 3, 4.
Okay. Probably. Okay. And once more. I would say like that. Probably without live transmission in my own lab, I would risk much more.
There was some displacement of the balloon.
Yes, we recognize that.
But based on what you take in the right
Now it's fine. Now
It's
it's
okay.
positioned ideally. Go to 18.
18.
Yeah.
but based on the
Okay.
on what
Record.
you have done in the right.
Okay,
coronary,
now we really
not the
opened, sorry that I interrupt you, this semi-compliant with 18 atmospheres showed me that this is not very rigid calcific nodule, so there is space for stent.
Yes, most
Now-
of our Egyptian patients at this age, they don't have that calcific disease
Yeah.
that you see in Europe.
That's what I had from my friends. So therefore I am very cautious trying to prepare the lesion properly.
Yes, that's why, we appreciate that. But as you have seen in the previous right coronary case, the stent went very well without it.
Yeah, but you know, I don't know these Egyptian coronaries as you know. I have to follow your suggestions. Okay. Okay. A big elastic recoil, but as everybody saw, there is a power to shift this calcific nodule. Okay, so my proposal for this particular case right now is a BIOS stent with proximal size 425 and distal part 3.5. The length, I would say that at least 19 millimeters. I will see what do we have. Okay, let's go with this. So because of the left main, the length of left main, I decided to take 23 millimeters long stent.
From the ostium.
Then we will probably not cover the ostium, but I don't care because the ostium looks quite well. Will not touch. Okay. Oh, yeah. We can show. Sorry. How does it look like? Could you focus? Could you focus?
Focus here.
Could you focus?
On the stand, please.
We are doing this.
And then it's visible two parts with small gap between them.
We don't see it well. Can you do more focus?
More focus.
Yes, now we
The
see.
distal portion is a little bit longer
Yes.
than the proximal one.
What is the total length of this stent?
The total length is 23 millimeters.
Okay, and this is 1/3 for the LAD and 2/3 or the opposite? 1/3?
Exactly 45% for left main, the 55 for LAD.
Okay.
And the diameter in left main 425 and
425 by 3.5.
and distal is 3.5.
Yeah.
And the balloon will go for which side? The carrying balloon.
The balloon is the same size because the balloon is bottle shape
Bottle shape.
with the proximal diameter bigger than the distal one.
Okay.
The issue in how to position the
I will tell you in a moment.
in front of the wires.
And this is a semi-compliant balloon. The stent balloon is semi-compliant.
Thank you very much. I appreciate it. Then you can appreciate. Follow with this thing. Now we'll see the three markers. You
Yes.
see? Look, without any problem with this very soft stent guide, we are able to position the stent. Okay, let's make a small angio. Okay. Now we have to position the mid marker in a tip of carina. So push.
Push, yeah.
Push. No. Push.
No, and the
Push.
carrying-
Okay.
and the tip of the
Now we'll make angio.
Yes, good.
And then I would say this is ideal position. Okay, let's inflate.
This is in front of Remus or in front of the
I
side?
will tell you just in a moment. Let me finish this stage, okay? Oh no!
Please.
He made okay because everything went okay. You have to push because everything went out. Okay, you have to keep it.
Continuous.
You have to keep it. Let's make once more angio.
Okay.
Probably, you see, the patient inflate, let's say, breath deeply, and we lost the position. Once more. Pull back to you. Pull back.
Good man.
Pull back. Okay, now it's fine. Let's make angio. We are too, let's say, we are too superficial. We have to push a little bit. That was ideal position. The same. We need to have the same.
We knock the top in
angio.
front of the circumflex ostium
Okay.
now, or in between the circumflex and ramus. The mid top.
Okay. This is 8 angio, no angio record. Okay, and then 14.
Up to 14.
Yes, up to 14. Make a registration. Okay. 15 seconds. The
what is
patient
the-
is very stable. The weight is 76. Of course, we have dump pressure.
For 30 seconds, you repeat.
Enough.
Okay, okay, that was deflection. Okay, 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 okay. So pull back the balloon. Yeah. The pull back the balloon, exactly. And let's make engine. Okay. Yeah, we will wait for wire. We'll wait for wire to get the pressure. Yeah. So sorry. Then we need to intubate a little bit.
Okay.
Okay, great.
Okay, I'm intubated.
Okay, so let's make angio. This is a moment of the truth.
Okay.
Asia.
Sorry.
Oh, that was my mistake. Okay.
Okay.
So you can appreciate that first of all we have opened the left main. We have very good access with the flow, TIMI free flow for circumflex artery and for ramus as well. So the question is, what do we need more?
We don't need anything
Let's make spider.
I don't think we need anything more.
Thank you very much.
Now, I don't know whether it's necessary to go proximal optimization with spot or no need. I don't know.
We'll discuss this
Since we don't have
moment.
IVUS.
Let me. Okay.
Since we don't have IVUS to optimize
take one more.
deployment in the left main, I prefer to go with high pressure balloon.
I will tell you like that. First of all, we have to think about the pulling back, the removal of the wires.
Yeah, wires will go out without a problem.
The question is whether we oversight the stent in left main or not. And then this projection showed us that there is still room to improve proximal part of the stent within the left main. So I would go with 4.5 and C balloon 8 millimeters long or 10, whatever you.
Yes, before the circumflex artery.
And the ramus has some disease, but I don't think we need to do anything.
You know, the disease is for sure. The some problem of compromise is for sure. But you agree with me that for such not big vessels, we shouldn't start to stent it.
Yes, we don't do nothing for that.
Then, when the natural shape of the vessel after pulling back the wires will appear, the flow will be better. You will never get it from, let's say, from the best stent. Okay.
Do we need to give nitroglycerin?
Why not? We can. We have still very good. Up to 140
Yes, it's high.
millimeters of mercury.
4.5.
4.5 10.
10 max.
لا بتكلم على البالونه 50.
So far we have only 5. I would suggest not to go so high. Why? Because if we use a finite formula, we see that LAD, this is 3.5, then 2.0 is ramus, 2.0 is circumflex, so in total this is 7.5. So please calculate 60% or 66% of this 7.5.
5 will be too big.
Exactly.
After nitroglycerin,
But you don't have 4.5.
So pull back the ramus wire.
I think you don't need to do anything more. This patient has a very good result.
So the question, my point is, if you don't have, let's say, ideal balloon, you have to think twice whether you should, because you know the better is the enemy of good.
Yeah.
So please.
There was a question from the audience
Yeah.
asking if you had IVUS ready in hand, would you go with the IVUS?
Definitely yes.
We said yes.
Because we have the proof from many papers that usage of IVUS increases the late outcome chances of the patient. Okay, so we have 4.5 and 6, great. Congratulations.
They found 4.5?
No. 4.5 is great. This is ideal balloon for such a case.
They found a 4.5 balloon.
Yeah.
Yes.
Yeah.
4.5, 6.
By 6, yeah. So, as you are able to see, this stent is really very user-friendly. So he has never seen this stent, but he was able to position
The
and to
sound
deliver.
is getting, we need to,
This is also very important to leave.
we can't hear you well. عايزين حد يظبط الصوت.
So,
Are you hearing me?
we need to know, now you are going to do proximal optimization
Yes.
by 4.5, 10.
Pull back
Balloon?
the
smaller.
wire from Ramos. They still inside. They see there. This is the same. Okay. But now we need this working projection, and since we don't have this. Okay, we don't have IVUS. It's very important to have marking points for proper pot. We shouldn't exceed carina position.
الميكروفون بتاع الخواجة.
What about the microphone?
الصوت بتاع الميكروفون اتحرك.
This is 6, and the distal marker should be on the level of the circumflex. It's okay. It's okay? Okay. Then first inflation,
How much?
10,
and then the second for proximal part.
2, 4, 6.
Up to 14. Up to 14. Up to 14. He moved a little bit, but doesn't matter.
40.
Okay, make a.
What is the pressure you play?
This is 14. 14. 14.
4.5, 14.
Yes.
Non-compliant.
Non-compliant. And the same for proximal part. Take care
removed
of
the
the
Remus
end
wire.
of the stent.
Right?
We removed the Ramos wire. We kept a wire for circumflex artery to position properly the balloon for pot.
It may give more protection for the guiding also.
Also.
Yeah.
I think
More support.
شريف عايزين نشوف الستاند. I think this
Yeah, it's okay. It's okay. It's okay.
12.
Flat
12, 14.
Okay.
Up to 14. As proper previously. Okay.
40.
14 again for proximal part. Do we able to make a stand boost?
No here.
No.
This no.
This is very good. This is very good. I recommend this technique at the end of the procedure, especially when you work with very aggressive guide catheter, because only with this technique you are able to see to look whether there is this longitudinal distortion, let's say longitudinal distortion of the stent.
There is 10 push. You can't last for the aorta.
معاك يا باشا.
Okay. Small injection. If everything is fine, we can move. Let's say we can remove the.
I don't think there is 10 push
Okay.
in the old Siemens.
Now we need. Okay, this is this projection. Please.
You can see the final.
Okay, let's make. Okay, so from now we see that after redilatation we have some impairments for circumflex artery. We need a second projection? I mean the spider.
Spider sheet.
There is no chest pain for the patient?
No chest pain, blood pressure is okay.
Okay, it's okay.
It's 120, 80.
We see the ramus is mildly affected in the proximal part and in addition the ramus. But if there is no chest pain, what's your opinion?
Okay, so in such a situation, I would try to gently dilate the ramus because you know there is something. Let's try to we need a new wire. We need a new wire.
A new wire for the ramus?
For the ramus, yeah.
So we'll do plotting for this scenario. We have now patient is completely stable, no chest pain, and there is some affection of the postal and the proximal ramus. Very mild affection of proximal circumflex.
But it will be good to see if the wire and the loon will go nicely and easily.
What I believe, deeply believe, that because of the stent design, the access to the ramus should be relatively easy. If so, I would gently dilate it. If not, I would leave it.
But you're not stented.
No.
Okay.
So now you will keep the wire in the circumflex and take
Yes, just to stay there, as you said, for stabilization of the...
and then dilate the side branch only.
Exactly.
No need for cutting.
Exactly.
No, so.
Okay.
But this is giving that you said, as what you said, the importance of wiring.
As you see, then, just a moment. Look at that. That was very easy using the reusable wire to find the ramus.
Yes.
The problem is inside the ramus, because there is probably a small dissection. May I try?
Okay.
Just to feel whether we should proceed or not.
You will,
Yes, okay.
That's okay.
It's okay. Because with the loop is safe. Okay.
It's okay.
And then what I would do right now is just 1.5 balloon.
بالون 1.5.
Not strong.
What is the length?
12,
1.5.
15, whatever you have. A regular one, not NC.
Rappel is asking you pass with the same wire PM that you used before.
Yes, exactly.
Not a new wire.
So just to show you that this stance gives you opportunity to get access to side branch very easily.
I use the old wire, the one I used before. And
Yes.
And the balloon also.
that means it is easy to pass it.
We don't have 1.5 on the table.
No, just
Yeah.
We will get you 1.5.
You won't get it.
just balloon to maintain flow.
Exactly, just to maintain the flow, just to correct the probably intima, let's say, some problems, because this is not typical dissection. I would say this is a kind of massage.
1.5 to
15.
Okay.
Okay.
Dissection with the
Not good.
branch just
Size is to give the
with
condensation.
with balloon insulation instead of main branch.
It's okay.
It's okay. And then after that, I think we should complete the case.
Do you think the possibility not dissection just flexion with double spasm, and if you try
This is a kind of spasm. This is a problem of endothelium.
It's okay.
It's okay. It's
You
okay.
see the balloon is going easy also. Now this balloon,
Yeah. No.
1.5.
This is 1.5
15.
with one marker. Let's say a mid marker,
Okay.
and then yeah.
2,
Just 10.
10.
Just 10.
Okay. Okay, 10.
Go to 14.
12, 14.
Do you need
That's
to go
it.
a little bit inside?
We'll see. We'll see. The orifice is most important because the struts of the stent squeezed the.
Yes.
No. Okay, now deflect. Small injection. What about the flow? Okay, a little bit further, the balloon.
That's okay.
Yeah, more. Okay. And now, again, the same. 10,
4, 6, 8, 10.
10, just a moment, and then up to 14. 14,
12,
right? Yeah,
14.
that's. This is a massage. But you see, the access of the balloon potential stent is very easy.
Yeah.
But hopefully we don't need it. Okay, pull back.
Okay.
How frequent, like the situation you was?
You mean trifurcation?
Yes, like after
In my, so we collected around 30 cases with trifurcation, and in 1/3 of the cases, the third stent or second stent is necessary.
Okay.
This is nitro,
Yeah.
and then we will see the result. Still good heart rate, blood pressure. Okay, that's all what we can achieve. So now I would pull back the wire from circumflex artery.
Okay.
Circumflex.
We need to see a better picture.
Yeah. Let us work on, because now we have 3 wires, balloon.
Let us take wires out and take.
Yeah, exactly. So I decided to pull back, take care of ramus wire,
Okay.
to pull back wire from circumflex artery.
This is the veins.
It's catching the wire from ramus.
لا أنا مش عايز ألمس على السر.
Circumflex.
That's okay. This is ramus.
Okay, the circumflex. You pull back, not this one.
This is the rings.
I asked for circumflex.
Oh, sorry.
Okay, pull back also the. No. Pull back the circumflex.
This is the sun.
Yes.
This one.
Yes, one.
Okay. Then keep the LED wire. It is always
Okay.
stabilize the situation.
Do you
And
need
then we need a good angio.
nitroglycerin. خلاص.
You have intubated.
Really good.
Okay.
Try to read.
Okay. And then the second, I wouldn't improve it. Not at all.
Do you want to remove it?
We need a second projection.
اديني الصورة تاني.
So, what is your suggestion?
We don't have any suggestion.
شيل ايدك بس من على صدرك ثواني. بس كده.
I see when the patient is not chest pain,
No chest pain and no ECG changes.
no ECG changes, and
blood pressure is okay.
suboptimal results in side branch is accepted.
Okay.
The follow-up is
Yeah, I wouldn't add any additional maneuvers.
because if you
Yes.
go with the higher balloon, we may need to stent out.
Exactly. The bigger balloon would force us to stent.
Yeah, right. So,
But to be honest, I would perform control angio in 1 month.
yes, right. I think
This is
so.
the last
We can
projection.
follow this patient and we can,
Exactly.
after 1 month by
And then the potential stents can be used, but hopefully it's not necessary. Because first of all, the dominant right coronary artery is let's say, cured with a big support for left side. The main vessel as LAD. Now I see that in distal LAD, they are, let's say, diffuse disease.
Yes.
So, but still, TIMI free flow, I wouldn't touch it.
Okay.
So, thank you very much.
Thank you very much.
Thank you.
Congratulations.
Thank you for support.
Thank you.
Thank you.
It was an honor to work with you.
Thank you. Thank you very much. It's a pleasure. Well, ميرسي يا شباب خالص. شكرين. خلصنا. مبروك.